If you would, please welcome Dr. Richard Warner from Mount Sinai Medical Center.
Good morning or hello to all my friends, patients, colleagues, and others. I'm delighted to see so many familiar faces and so many people eager to learn. The important issue overall here is you are a very, very mixed group. Some of you are very medically naive. You don't have much of a background technically, and you may not understand even some of the terms that are used, and I hope to help with that. Others of you are very medically sophisticated. You're veterans of the neuroendocrine tumor wars, so to speak. You've been through the whole routine, and you know more than many physicians about your condition. And here we're talking to you and trying to help educate or bring you up to date on what's new, what might influence your care in the future, to assist you with decisions. You're such a widely spread, educated group that it's difficult to find a way to be knowledgeable to each of you, but we'll try anyway. Those of you who knew my deceased wife, who was very interested in carcinoid cancer and other neuroendocrine tumor support, would appreciate a little story I have to tell. When I would prepare to make a lecture and come up on the podium as I am now, I would often ask her, what do you think, what are your last words of advice for this particular audience? And it was always the same thing. She said, KISS. For those of you who don't know what KISS means, it means keep it simple, stupid. So, although I don't like to be called stupid, I'll keep it simple. The first thing is, and you saw this alluded to before, in diagnosing carcinoid, but before I even elaborate on that, I should state, there are a number of you here who don't have carcinoid, of course. And just to make it clear again, neuroendocrine tumors are a particular variety of tumors. Like the term canine covers a whole group of dogs, but there's all kinds of different varieties within that. Well, neuroendocrine tumors covers a whole group of tumors. It just happens that carcinoid comprises 75% of that group. So much attention, or most attention, goes to carcinoid. But much of what has to be said applies to other neuroendocrine tumors. And most of these others, the 25% that aren't carcinoids, arise in the pancreas, and those are called PNETs, or pancreatic neuroendocrine tumors. Some of them are very, very specific in that they make hormones that don't characterize any of the other neuroendocrine tumors. Those hormones cause particular symptoms, like gastrinoma is the name of one such tumor, and it makes gastrin, and gastrin has particular features. It causes severe ulcer disease, as well as diarrhea and certain other features. And then there's insulinomas. These are insulin-producing tumors, and they cause hypoglycemia, same as an overdose of insulin. This is not at all like what an ordinary functioning carcinoid would do. And so there are a whole variety of other, all extremely rare tumors that arise from the pancreas, which cause specific syndromes and by elaborating particular hormones. They deserve special consideration. I'll touch on them slightly, but it should be in your awareness that many of the newer drugs will work on all of these, and so we'll apply most of our presentation, though, to carcinoid. And here you see, for the diagnosis of carcinoid, and there are two groups of you here, those who've been diagnosed and those in whom it's suspected, but most of you are diagnosed. And the first thing, though, in diagnosis, when you present to a physician, is he's got to think about it. In other words, when you hear hoofbeats, you got to think of not just horses, but a possibility of a zebra there. So suspicion comes first. If it's thought of, considered, suspected, then the right tests can be implied, and then most of the time the diagnosis will not be that difficult. The next thing would be markers, to measure in the blood or the urine the hormones, the particular substances that these tumors produce. Some of these tumors produce, as I said, very specific things, but most of them will produce some general substances which are characterized by all of them. For example, chromogranin A is a protein-like substance that's produced by most neuroendocrine tumors. There are a few exceptions. For example, insulinomas don't always produce these. In fact, maybe less than half of the insulinomas produce it. But most of the other neuroendocrine tumors will produce this type of marker. So the doctors have to be aware of what the general markers are, and on specific things like serotonin or 5-HIAA characterizes more than 80% of carcinoids. Although they may not all have the syndrome, most of them will produce some slightly increased measurable product like this that can be used both for checking the diagnosis and also for evaluating response to treatment. We also then have, as part of this group of items that are needed for diagnosis, imaging. We've got a whole bunch of different imaging techniques, but you've got to see and localize the tumor to be able to treat it. And so we'll discuss imaging a little bit further. And finally, to prove it, we need a tissue diagnosis. We need a biopsy. And you can't biopsy if you don't know where you have to do the biopsy. So you've got to see the tumor to be able to do the biopsy. Sometimes we have cases that have all the right symptoms, all the right chemistries. We can't find the tumor. That's infrequent, but it happens. We have some new imaging techniques that assist in that regard. All right, again, for midgut carcinoid tumors, that is, tumors that arise in the distal duodenum all the way down to the mid portion of the colon, mostly in the small intestine. The commonest presenting symptoms are abdominal pain. Well, that may be intermittent, it may be slight, and as you heard, it can occur many years before the final diagnosis is really established. And these patients are often carried as irritable bowel or maybe Crohn's disease for a long, long time before the right diagnosis is achieved. And this is understandable because abdominal pain is such a common occurrence that we don't take everybody who gets an occasional bellyache and do X-ray studies of their abdomen or do complicated blood tests. So a great deal of judgment comes into play here. Eventually, though, with the typical midgut carcinoid, intestinal obstruction may occur, and that brings the patient perhaps to acute attention, and then lo and behold, at a necessary emergency surgery, a carcinoid is found, totally unexpected. It's good that it's found, but it's disappointing that it has to be found at such a late date, and that the diagnosis is made after the opportunity to do all these tests ahead of time, which is so important because we can use them for comparison with tests later to evaluate the completeness or the adequacy of the surgery or the effectiveness of resection. A good number of patients have the diagnosis established incidentally. They're being operated for something else, appendicitis, gallbladder disease, and lo and behold, carcinoid is there. A smaller group will present with bleeding, rectal bleeding, as the first sign of something wrong. And then a smaller group will present with a mass, a lump in the belly that can be felt. Sometimes a patient will go to the doctor and say, I've got a big bump here, what is that? And then a smaller group will present with features of the carcinoid syndrome, either prolonged diarrhea, which has defied diagnosis, or flushing, episodic facial flushing, maybe just once or twice a month after drinking some red wine. But this will occur. Only between 20 and 40% of all carcinoids in the midgut will actually have the carcinoid syndrome. It's not that common, but it's very flamboyant, it's very impressive, and so it's received lots of attention. Now, carcinoid of the lung, which comprises some 28% of all carcinoids, has its own particular features. It is often an incidental finding on a routine chest X-ray. There may, on the other hand, be blockage of one of the airways, bronchus, so that there is recurrent pneumonia, always in the same section of the lung. We may get coughing with coughing up blood. We may have just a plain dry chronic cough. We may have distant metastases. That is, it first presents when there's a lump in the liver. And then we may have an endocrine syndrome, not just carcinoid syndrome, but lung carcinoids are famous for being able to produce many other types of syndromes, in particular Cushing's syndrome, due to excessive production of ACTH, which causes a cortisol production, which ends up causing flushing and high blood pressure and other symptoms. Here, looking at a section of small intestine that's been cut open, you can see in that section several little nodules. These little bump-like excrescences are characteristic carcinoids in the small bowel. They don't look very imposing, but yet if you take this and you magnify it on a cross-section, you can see that the lining of the intestine, the mucosa, covers it. It is a submucosal growth, and this layer is the muscularis propria, the muscle coat of the intestine, and you can see tumor streaming through it, these little yellowish columns. And here on the outer surface of the intestine is the serosa, and this tumor has grown down into the serosa. So it's gone through the full thickness of the intestinal wall. This is already a rather advanced tumor, and just nipping it off with a biopsy forceps with a colonoscope from internally is not going to take care of this part here, because it's likely to have already spread at least to regional lymph nodes. So this awareness is very important. It may take several years for this to evolve, and therefore it has the misinterpretation of being practically benign. It isn't, as you know. All right, the markers. Well, the main ones we know are the urine 5-HIAA, 5-hydroxyindolacetic acid. It's the metabolic waste product of serotonin. Serotonin is the product in the blood of these tumors, and chromogranin A, as you heard me mention, is also a substance but doesn't have any clinical action in terms of making symptoms, and it's also released by most other neuroendocrine tumors, so it's very useful. However, it is thrown off, it's altered by a wide variety of medications and other influences. For example, if you eat, that will give an erroneous elevation of the chromogranin A. It'll also do that for serotonin. All these tests have to be done on a fasting stomach. The 5-HIAA in the urine is a 24-hour urine collection. That's inconvenient, and it also requires you to avoid certain foods that contain lots of serotonin, which will increase the 5-HIAA in the urine. More recently, tests of the blood 5-HIAA have been developed and are just becoming available, and that saves the prevents the need for a 24-hour urine collection. Here, this complex chemical pathway shows what happens in the formation of serotonin and the ultimate metabolism into 5-HIAA. I would point out several things, and I'm going to make you all amateur biochemists in so doing. Tryptophan is an amino acid. It's one of the building blocks of protein, and it's in the food that you eat. Not everything, but certain foods. And it's an essential amino acid. That means you can't make it in your body. It's got to be obtained from external sources. Therefore, you have to eat food that contains tryptophan, and tryptophan is the basic building block for your muscles and protein, and also is what one of the B complex vitamins, nicotinic acid, niacin, comes from. And in the instance of a very active carcinoid tumor, your tumor may be gobbling up so much tryptophan to make serotonin, because that's one of its products also, that niacin synthesis suffers, and patient becomes deficient and may develop subclinical or actually clinical evidence of a disease called pellagra, which has as its characteristics fatigue, diarrhea, a particular type of dermatitis, and effect on mental function, the 3 Ds, diarrhea, dermatitis, and dementia. And of course, with carcinoid syndrome, you don't need to have this on top of it. And it's so simple to take care of. All that's required is to take supplemental niacin. Anyway, in absorption through your intestinal tract, tryptophan gets converted to 5-hydroxytryptophan, which is the precursor from which the tumor makes serotonin, 5-hydroxytryptamine. There is now being developed for clinical trial a drug that will interfere with the formation of 5-hydroxytryptophan and thereby reduce the formation of serotonin and hopefully help the symptoms and perhaps the pathology, the disease aspects that are attributable to the excess of serotonin in carcinoid. Clinical trials are just starting throughout the country of this new drug. At any rate, serotonin is converted to an intermediary substance, 5-hydroxyindole acid aldehyde, and the aldehyde is converted to 5-HIAA. And so the 5-HIAA in the urine is not likely to be very elevated if we don't have increased serotonin. They go together. And as I said, we can now do a blood test for that. So those are the main markers, and here is a list of the different conditions which can give a falsely elevated chromogranin A. And this is important to know. It's not always realized. I must say that I see perhaps one patient a week sent to me with a suspicion of carcinoid because the doctor found elevated 5-HIAA. And what he didn't realize was the patient was on a PPI drug, proton pump inhibitor, such as Prevacid, Protonix, Nexium. Those drugs will increase the chromogranin A, and that increase will persist for as long as a month after you stop the drug. Consequently, it's not a useful indicator for carcinoid or other neuroendocrine tumor under that influence. If there's impaired kidney function or impaired liver function, then the chromogranin A will also be elevated. And as I said, they must be fasting. Eating will increase it. We don't have the problem of retained gastric antrum so much nowadays, but it used to be a frequent problem because of the frequency of surgery for stomach duodenal ulcers. There are a number of conditions that can cause elevated blood gastrin, and one of them is gastrinoma that I mentioned before, and the other one is atrophic gastritis, that is a atrophy of the lining of the stomach. Both of those conditions can cause elevated chromogranin A also without carcinoid being present. Although in atrophic gastritis we may get small stomach carcinoids, but they don't usually cause serotonin to be up. In inflammatory bowel disease, such as Crohn's disease, if it's very active, we can get elevated chromogranin A. And if there's real physical stress or trauma, for example, I saw some patients who were marathon runners, and they would have rectal bleeding and diarrhea after running a marathon, and somebody said, oh, they might have carcinoid, and they were red in the face. Well, if you ran 26 miles. Anyway, their elevated chromogranin A brought them to me, and we discovered that if you stop them from running, at least for a week or two, their chromogranin A goes back down to normal. So chromogranin A is a good test, but you've got to recognize it has limitations, and its results have to be properly interpreted. Now, other carcinoid tumor markers, which are less frequently used, but nonetheless can be very important and helpful. In particular, I'd point out pancreastatin, which has been unavailable in New York State up until very recently. Now we can get it done again. Is a substance produced mostly by carcinoids, but by some of the other neuroendocrine tumors. And in my judgment, and I think Tom Odoricio will agree, is a very sensitive indicator for carcinoid tumor. And in some instances may be the only indicator. Neuron-specific enolase is a very non-specific indicator. Substance P is helpful. Pancreatic polypeptide is more helpful for pancreatic neuroendocrine tumors. And neurokinin A is another non-specific substance. And in some cases, very few, alpha or beta subunit of human chorionic gonadotropin is used. I find it's useful to do a full panel of all these tests the first time I see a patient, and then whatever's elevated we can use for following thereafter. Now, I mentioned before various specific tumors other than carcinoid that made their own hormones. And here you see them listed: gastrin, insulin, VIP, glucagon, calcitonin, ACTH, and then the adrenaline-like substances made by pheochromocytoma. This is an adrenal medullary tumor that causes severe hypertension and flushing, and also paragangliomas. These we won't dwell upon, however, because of the limits of time. Under imaging techniques, and you were exposed to some of them before, but we'll just review. This plain, straight, conventional X-ray may be very helpful, and I'll show you an example. CT scan, which means computerized tomographic scan, that's what the CT stands for. MRI, magnetic resonance scan, ultrasound scan, isotope bone scan, and then the gold standard at present, which I think some will tell you that it's going to be replaced by gallium scan, which is not yet universally available, but is available in this country on an experimental basis at several centers. The Octrio scan is very helpful. The SRS means somatostatin receptor scintigraphy. The FDG PET scan, what is known as the standard PET scan, that means fluorodeoxyglucose. And that scan is dependent upon the aggressiveness or the activity and growth of a tumor it's scanning, because tumors cells are usually growing at a more rapid rate than the rest of the body. They need energy, so they take up glucose. So they attach an isotope to this deoxyglucose molecule, and it gets carried to the actively growing tumor and then lights up on a scan. And since most neuroendocrine tumors, at least carcinoids, are slow growers, they don't light up on a FDG PET scan, which would light up on most other types of conventional cancers. Therefore, as you heard, the regular PET scan is not that good, certainly not as a first step in trying to diagnose carcinoid or some other neuroendocrine tumor. We also now fuse the Octrio scan electronically with a CT scan, so it helps to localize the spot that lights up on the Octrio scan. And then finally, we have the MIBG scan. This stands for a chemical name of a substance to which is attached a radioactive iodine, and this will light up in a minority, but important for each case, of carcinoid tumors, and can be a help, and is used in particular for pheochromocytoma. All right, here we have a straight chest X-ray, and you see the black area, which is the lungs, the ribs, the heart, mainly to the left side, and here a pencil mark around an area which you really can't see too much wrong on this particular picture, but a sharp-eyed radiologist picked out something, and if you look at it real close and follow the contour of the rib here, then it breaks, and there may be even a little mass there, then it continues. So here's a fractured rib because of a metastatic tumor, and the patient was complaining of chest pain, and it was tender over one spot. So this is useful, standard X-ray for a patient as the first step in diagnosing. Now, here's another. This is a barium swallow, upper GI series. Not used that much anymore, unfortunately, because it's been replaced by the technology of doing an upper GI endoscopy. This is cheaper, less invasive, and still plays a role. And you can see this column of white stuff, which is the ingested barium, and it goes down into the stomach. And that's an upper GI. And then you follow the barium through into the intestines, and this is a follow-through GI exam. And you can see here the stomach still with barium up in the corner, and then all this white stuff and loops of intestine, and finally it goes into the colon over here. And if you'll notice, the stomach is still full of barium while it's gone all through the intestine and reached the colon. This means rapid transit. It went through the system faster than is normal, characteristic of the diarrhea of carcinoid. And this shows the same thing again. The stomach is full of barium. You see it in all the intestine, and it's reached the colon. So this is a standard GI series. Now, here's another type of treatment or of procedure. We see here a column of contrast. This was injected into the femoral vein in the groin, and this is the inferior vena cava, the biggest vein in the lower half of the body, carrying all the blood back to the heart. And you see there's a big narrowed segment here in the middle. And here, looking at that again, we see the narrowed segment, and we see little branches going around it, collateral vessels. This was an area that was compressed by tumors in the retroperitoneal node, lymph nodes in the back of the abdomen, and they were narrowing this vessel, and as a result there was great swelling in the feet, and there was fluid in the belly, the so-called inferior vena cava obstruction syndrome, and this demonstrated it, and then this was treated by the insertion through the catheter of a stent, a wire mesh tubular thing which springs open once it's put in and holds the narrow segment open, and here you can see it. And now, afterwards, the venogram, the contrast, shows the way it ought to look. And so this is a big help. This is not curative, but it's certainly a treatment that alleviated a symptom and helped a great deal. And of course, on imaging, we have CT scans and we have MRIs. They each show, as in this picture, many, many large metastatic tumors in the liver. And then we have the Octrio scan, which shows you the normal uptake in certain organs. For example, here's a vague outline of a person's head and their torso. This dark spot is the urinary bladder because this radioisotope is excreted through the urine, so it concentrates there. It concentrates in the spleen and in the liver, in the kidneys and the liver. But there are hot spots, particularly prominent areas of metastatic tumor, carcinoid in the liver. So that's a Octrio scan. And then we have angiogram. We don't use that much for diagnosis anymore, but it can be used, and in addition, it's used for treatment, which I'll describe in a moment. And you see here a catheter that was inserted through an artery in the groin, and it's insinuated up to the artery that goes to the liver, and that in turn feeds big tumors, these big round balls in the liver. And these metastatic tumors can be infused with medicines or particles to block their blood flow through a catheter, so-called HACE, hepatic artery chemoembolization, or radioembolization, etc. And here you see it again, very discreetly. This is what's seen in the course of doing an hepatic artery angiogram. And this is just showing, for those who really don't know what it is, what an endoscopy is like. And you can see the scope being passed into the stomach. and looking down inside, or through the rectum into the colon. And here, looking in the stomach, is a picture of a small gastric carcinoid, this little ugly-looking wart-like structure, and the normal lining in the stomach. And this is another form of imaging, the ultrasound scan, endoscopic, in the rectum. And here, this device shows itself in the middle of the rectum. And you can see this is the rectal wall, the lining, and here's a bump in it with a shadow underneath. Magnified, it's right here. That's a tiny rectal carcinoid. And you can see how deep it goes or how shallow it goes by this endoscopic ultrasound. This is used also in the upper GI tract and the pancreas. And even biopsies can be taken by passing a needle through it. So this is a very useful technique. And this is indeed looking in the pancreas through an upper GI ultrasound. And you can see here a big round structure, which is partly cystic, the black stuff, and partly solid. So it's a complicated cystic lesion, which was a PNET. And then finally, another way of imaging is the capsule endoscopy. You swallow this big pill, which is not too bad to swallow, and in it, it's got a lens, it's got a battery, it's got a flashlight, and it's got a telemetry device that can send images that it sees 2 every second, up to 56,000 images as it passes down through your digestive tract and eventually passes out and is flushed away. And then all these pictures can be viewed later, and a carcinoid or some other tumor or some other disease like Crohn's can be diagnosed in the intestine. Patient comes in the morning, gets strapped into this with these leads like an electrocardiogram, and wears a little box on a sling around their shoulder or on their waist for the day, then comes back at the end of the day, and all of this is taken off, and the receiver in that box is downloaded into the doctor's computer, and then he can look at the pictures. And here is one such picture, and you can see a bulge here, and here the normal lining, and this was a submucosal tumor, which happened to turn out to be a carcinoid. So finally, and I'll be very brief, we've had comments about treatment. Just to say it can be divided into 3 types: supportive measures, which means non-surgical usually; surgery, which can be both curative or palliative; and then finally anti-proliferative measures that interfere with the growth of tumor. A plug, I should say, for radiomicrospheres, radioemboli. I find it much better and more desirable than chemoembolization. 1, it doesn't require hospitalization. 2, the after effects are a bit gentler. And 3, it probably has its beneficial effects lasting longer than chemoembolization. But in interest of time, I won't dwell upon this. All right, conclusion. As you can see, there are many, many diagnostic procedures, many treatment procedures that are available, both to supplement, to replace, or to indicate the need for and guide surgery. The timing, the character is very much open for discussion because there is no one that's absolutely preferred or is standardized, and everything has to be customized. And much depends upon the expertise of the doctors making the decision. You heard the benefits of multidisciplinary approach and treatment, and I agree completely. The problem in that regard, however, is that such facilities are not generally widely available, although every institution usually has a tumor board, a group that gets together periodically, maybe once a week, to review problem cases and come up with decisions. The tumor board is made by earnest, sincere, and well-qualified doctors, mostly oncologists usually, and not necessarily experts in neuroendocrine disease. And the problem is that the unsuspecting patient may think that their problem is being handled in the very best way. Not necessarily so, because it depends upon the experience and expertise of the members of a tumor board. And if they're deciding what treatment should be, that's really a committee deciding on the basis of treatment. Well, there are some things that can be said against committees deciding like that. It's been said that a camel was a horse designed by a committee, and indeed, unless the people who are serving are really true experts in the field, it's a caveat emptor. So buyer beware. So you've got to know who's making the judgments about your care. Finally, because of the variety of treatments and approaches and the various expertises available, even the experts don't always agree. I thank you.